All right, it is an absolute pleasure to be here today. I was in your seats probably about a dozen years ago. I am a convert. I'm like a walking advertisement for the EDBA and process improvement. I saw a show of hands earlier today. I think it was about 50% of people were EDBA members. I would say if you're not, you should join. I will tell you either today or, for example, later in the workshop, reasons why that data will be integral to the work that you do. So it's a pleasure to be here. As Sherry mentioned, I'm from Brown, from Rhode Island. We have 5 emergency departments. We actually fit almost all of the categories that Mike talked about earlier today. We have about a little over 250,000 visits. We have a pediatric ED. We have EDs with volumes of 20 to 40,000, 40 to 60,000, 60 to 80,000, and 80 to 100,000. So everything I'm going to talk about today has some version of what in one of these EDs, and my job is the clinical oversight of all of them. Before I get started, just a quick show of hands so I know a little bit of who I'm speaking to. How many of you have an ED that's 20 to 40,000 visits? Okay, how about 40 to 60,000? Okay, 60 to 80,000? Probably about the majority there. 80 to 100,000? All right, anybody over 100,000? All right, we got a couple of people in the audience. Great, so a really good mix that I think I can speak to. And then the last question I have for you is how many people have boarding the averages on a day-to-day basis over 20 patients? Okay, 30 patients. All right, well, we're in good company. I'm one of those places. For those of you who don't know about Rhode Island, it is like, it is probably the epicenter of what would cause ED boarding or boarding in general. We have perhaps one of the sicker patient populations in the country. We have a pretty low income, disabled, older population, and we are perhaps one of the worst reimbursed states in the country. Anybody from Rhode Island here, by the way? All right, I didn't want to talk badly about that. So, having said all that, it's really beautiful if you ever go there. But it is probably the epicenter for something like this. There's a poor primary care network because of the reimbursements poor, and so you have a lot of patients coming to the EDs, and because they're older, sicker, they get admitted, or admission rates are higher, and so there's just a lot of boarding. And one comment I would make up front, I made the mistake already. If there's one thing there's 2 things you can take from this talk. It's before I even get to the talk, which is 1, it is not ED boarding, it is inpatient boarding in the emergency department. So I encourage you, when you leave here today, it is inpatient boarding in the emergency department. Every time you talk about it in your institutions, that's the way you should phrase it, inpatient boarding in the emergency department. The second piece that you may or may not be aware of is that Leapfrog in the next couple of years plans to grow hospital reporting to include ED patient safety measures. If you just Google it like Leapfrog, and I think boarding and emergency departments, you'll see the first thing there. It's like section 6E talks about how they plan to start including boarding in the Leapfrog grade. So that's one thing you can take as a thing in your back pocket when you go talk to your system administration. Sorry. All right, now I'll get started. I break this up, as Sherry mentioned, as a framework. Process improvement as a framework for me is the things that are external to the emergency department, and then there's the things that are internal. Internal, in large part, are what we have control over here in our, those of us here. External is the things that we do interacting with the outside the ED, whether it's hospitalists, whether it's the executives, the C-suite, other departments. That's sort of the external part of it. We have a role to play in both. In fact, I will tell you a lot of times we at Brown Health and Brown Emergency Medicine are heavily involved in the external piece because we know how much it drives our ability to function as an emergency department. Boarding is the greatest, as no secret to anybody, is the greatest source of dysfunction in our emergency departments. And having some role in hospital process improvement will improve your ED process. So I will describe them in 2 different things. Heavy lifts are the type of things that we can't really do here today. We can't take this home and say, let's do this. because they're kind of the panacea. They're the things that require system leadership. They're the things that require executive buy-in. They often require strategy change, FTEs, infrastructure change. Those are the things I'll show you on the next slide, are the things that we would love to do, but they take a while to happen. The lighter lifts are the things that I think we could each take one of these things home if you're not doing this already and bring it to your hospital leadership, bring it to the people you work with, and try to implement it in your location. And most of these are ones that we've done in our centers. So as a quick side point, I'm obviously happy to talk to anybody about your operations and what we do after this. Later today at the workshop, at any time, email me, contact me, etc. So heavy lifts are those, as I said, what you see published. It's the surgical smoothings. You need to have a command center. You need to have a system surge protocol. You need to use hallway beds. These have been published. We know about these things. Those are all, like I said, panacea. We would love to see those, and if you do have those, you're probably not at this conference, because those would solve much of your boarding and process improvement issues from the hospital side of things. But we can take things that we can do from what I would call a lighter lift, and those examples you see on the screen. For example, we have an ED surge plan. I think I saw Queens Medical Center has a poster up there about their ED surge plan. When we get in a certain state, we have a level of boarding and a level of arrivals that gets to a certain criteria. We call code ED surge over the hospital speakers, not in the emergency department, over the hospital speakers. There's a workflow associated with that now. That includes dedicating 1 to 2 inpatient nurses coming to the ED to manage boarders. That includes many other pieces that involve moving patients to the floor, and I'll get to hallway beds. It includes a lot of the things on the right-hand side of the screen, essentially. Okay? Instead of talking about surgical smoothing, you start talking about PACU holds. It would be nice to go to your hospital and say, we want to solve things by having surgical smoothing. Our boarding on Mondays and Tuesdays will be much reduced, and that will solve sort of the problem of what we all see, which is that boarding is usually worst Monday, Tuesdays, and then kind of slowly gets better throughout the days. But if we just solved it by surgical smoothing, nice, but one thing you could take is start to just ask for PACU holds on days where your ED's in surge. Another thing you do is, there are some locations in the country that have hallway beds routinely. That's a very difficult sell. I've tried to make that sell multiple times, I can tell you that much. But what we've been more successful is hallway beds on discharge of the patient. So a patient's discharged from the hospital, they are now no longer hospital level of care. They're going to go to a hospitality, we call it a hospitality lounge, or they're going to go get discharged. But the reality is, you've acknowledged by placing that discharge order, they're no longer hospital level of care. But the inpatient boarder in the emergency department is. So we've successfully made the argument that upon discharge order, we can move patients in surge up to the hospital floor. So at one of our locations, it's just they go to the hallway when we're in surge. In our other locations, it's when they're discharged, they go to the hallway. Okay, and so that creates obviously space in the ED for arrival care. Repatriation is another example. I know a number of you are 80 to 100 or greater than 100,000, so many of you are probably tertiary referral centers. So you get patients brought into you, in some cases unbeknownst to the ED leadership and the people in clinical care, and those patients are brought directly to because they're accepted because you're a tertiary referral center. Smaller step is to go to that command center and say, hey, when there's tertiary referrals that are necessary, but don't necessarily need to be sent at that moment, can we wait till the surge is improved? This patient needs an ENT consult, IV antibiotics, to stay in a hospital that has ENT. They may not need that ENT consult immediately. They might be able to come 4 hours later. Do you have repatriation agreements? That same patient can come get their ENT consult. ENT says no need for anything. And then if that patient needs inpatient admission, you repatriate them back to the facility from which they came. Does that solve your current boarding problem? Maybe not, but it certainly doesn't make it worse. Okay, so all of these are sort of like the lighter lift that I think we can take back to our hospitals. And instead of trying to make the big jump to surgical smoothing and all hallway beds and what have you, we make that smaller incremental jump. And trust me, we're going to try and make that argument for the heavy lift someday in the future. But until we get that buy-in, we're in the lighter lift. And each of those, if you do all of those, will have substantial impact on your ED before you do any internal process improvement. Okay, internal operations. This is a diagram that is in the last consensus conference. The publication for the next consensus conference will be coming out in journal JSEP Open later this year. This diagram basically is your sort of your flow map for your patient with timestamps in it. Okay, when I talk about internal operations, I break it up into 3 pieces. It's arrival to provider or intake, provider to disposition or doc to dispo. Now you're going to hear me call it as active care time. I call it active care time because doc to dispo often implies that it is this is all the doc. Okay, now we had this intake, we had this discharge part, and everything in the middle is the doc's responsibility to move that time down. In reality, it's not. In reality, the doc to dispo or active care time is just that. That is the majority of the length of stay of the patient. It's the majority of the time where things are being done. But the majority of things that are impacted this time are actually not so much the doctor. They are lab turnaround time, radiology turnaround time, consultant turnaround time, or the absence of those, not doing those things. So what we do, decisions we make are largely made at that break point between intake and throughput, and the consequences of them carry out through the provider to disposition. But those consequences we can have process improvement on, and we talked about that a little earlier today. And then the last part is outflow. So like I said, I'll break these up into 2 pieces. Again, intake we talked about earlier today. Intake is the thing that you're going to see most, obviously, on the C-suite level, right? They're going to hear about door-to-provider times and left without being seen. Left before treatment complete being obviously the one that is used through the EDBA. Much of the executive suite, you're using one or the both. But the reality is that they want to hear those 2 things. And the reality is that most of that is affected heavily by how much boarding you have. So you need to divorce yourself from your intake process and your boarding, which means you need to devote resources up front. And then obviously the KPI for this is often door-to-provider time or left without being seen percentage. So here are some couple of things that we talk about pre-triage. So pre-triage, do you have or have you investigated telemedicine or teletriage? I know there's 2 examples of that in the back of the room. I think South Carolina and Advocate have examples of virtual triage. I know Jefferson's an example of teletriage. We've done a little bit of teletriage. If you're part of a system, that's the ideal scenario, in my mind, is that you use teletriage not just for your one singular ED, but maybe to siphon off the low acuity visits across all of your 2 or 3 EDs, and you have one person in one place doing that teletriage. So that's one consideration pre-triage. Same day, same site access. Again, since the majority of people here are probably 60,000 plus, you probably have clinics on site. If you're an academic center, you certainly have clinics on site. And utilizing same day, same site access after medical screening exams is another thing that you can do pre-triage. This siphons patients off of the ED into the clinics. Many people know the clinics have at least a 5 to 10% no-show rate. Many of the primary clinics that are referral clinics in academic institutions, it's even higher. So take advantage of that. Find that out, take advantage of that, and ask for that no-show slot. They're not filling it with anything else. Fill it with an ED patient. ED appointment scheduling, I don't know if a show of hands, anybody does that here? Okay, a couple of people. We don't particularly do that, but what we do is urgent care scheduling. So you go to the website, if you were to look for, the door-to-provider times or the information about an ED, there's also urgent care centers associated with our system, and scheduling people into urgent care center as an option is another piece. So I'm going to talk now about the intake process. You've probably heard these terms, but I just want to be clear about what I'm trying to say. Provider and triage. An APP or an attending physician in triage who does the medical screening exam, initiates care, and further directs the triage of the patient. This is sort of the quarterback, if you will, of the patient care process, okay? This is not, as you'll notice, the person that just does a medical screening exam. This is the person who is a point person of the intake team who gets the care done. I think it was Jim Augustine earlier today who said the goal is not to just hit a provider, it's to hit a provider and have things happen. So really ramping up that intake process as part of a team, which I'll just talk about in a second, is how you're going to actually function in a high boarding environment. Split flow models is, we all kind of do it in many of our EDs. You have a fast track. You probably have potentially a vertical model, which I'll get to. But split flow models are independent workflows for specific subtypes of populations, usually delineated by ESI. Fast track's one of them. Okay, I'll talk about another split flow model, if you will, that we use, which is in effect using the waiting room. And I know there's a poster from Plano, Texas, on that, using the waiting room for patient care. So, and then the vertical model is operational flow model designed for patients who arrive vertical, or other people describe it as for patients you hope to keep vertical, meaning not all patients, in fact, the vast, vast majority of patients don't need to go into a gurney. They can come, they walked in, they can walk to a chair, they can walk to a lounge chair, they can walk to a, to get their x-ray, to get, bless you, to get their CT, and then go back to a waiting area or another bed space. So variations on intake models. We've done this for years. We just haven't ramped up to sort of a lot of times get to the most innovative, if you will. And we're innovative by necessity here, right? We're adaptable emergency clinicians. We're adaptable as administrators and nurse leaders because we have to be for the level of boarding. Obviously, we try to take it to the next level because of the level of boarding that we have in our EDs. So how many people have pull until full? About half. Okay. How many people have nursing protocol orders? Okay, about half. Now, I would suggest to you if there's those two things alone will make a big difference. Pull until full is essentially this. Very simple. If there's a bed, it should be filled. Unless you're in a trauma center, in which case you need to keep your stroke and trauma beds open, you should fill a bed no matter what. We do this in our institutions. It doesn't matter if this is the high acuity bed. Put an ESI 3+, I'll explain who those are, 4 or 5 into those beds. There's no triage that needs to happen. There's an available bed, there's an available provider, there's an available staff. There's no triage that needs to happen. Put them in the bed. Stop wasting time up front having someone triage this individual when you know that there's a bed available to them, assuming the bed is not obviously a chair and you're putting a higher acuity patient. So pull until full. That's one thing you could take away today. If you don't do pull until full, try implementing that and make a significant difference. In many of our EDs, you'll have like a critical care bed with an ankle sprain sitting there. They can be cleared out if a critically ill patient comes, but they got seen. Okay, the bottleneck shouldn't be intake because we have one person there. It should be flowing out into the rest of the ED. Nursing protocol orders is another example. If you don't do that, I would take that back and say that that's effectively, in some ways, standard across the country. We should empower our nurses with very expansive protocol orders to be doing this in our EDs. If you haven't done that, you'll see a substantial improvement in efficiency if you do that. Okay, provider and triage. How many people have provider and triage? Okay, about 50%. Okay, so about 50% of people have, how many people have an APP in triage as that provider? Okay, and how many people have a physician? Okay, so it's about 50-50. So you can take this two different ways. A lot of people, we do this in one of our scenarios, we use an APP in triage. That person's job is to effectively initiate orders on higher acuity patients, but to siphon off the lower acuity patients. The more complex provider in triage with the physician in triage, particularly you see this at the higher volume centers, is that's the quarterback of the team being provider in triage, triage nurse, nurse in triage, tech, you name it, that helps get flow. It's an intake team. And then I'll skip 4 and just talk about ESI 3+ patients. Like I said, I mentioned one of the institutions here as a poster. We have identified over time by necessity, right? We have 4s and 5s that now make up only about 11% of our volume. And then we have higher acuity patients, And then we have the ESI 3s, which are a big, big bucket of patients. An ESI 3 with severe abdominal pain, abnormal vital signs, let's say that's an ESI 3, but gets a bed, right? Or gets at least a vertical bed. You're going to need to see that patient, intervene again, give them more pain medication, see how IV fluids worked, etc. Person comes in, trips and falls, hits their head, needs a CT scan. Does that patient need the same level of resources? Right now, if you just used a bucket of a vertical model, they would get that. I call those ESI 3 plus patients. They're not ESI 4s and 5s, but they have the same real level of resource utilization. In our scenario, those patients we call flex track because they get added to the fast track patients, and we'll get them, they'll get seen, a nurse will get them a Tylenol, what have you, if that's in this scenario. They will be brought from the triage rooms to radiology and then back from radiology to the waiting room to await their results and back into triage. Okay, they never touched a bed, right? They never touched a bed because beds are a premium in our institution because we are in that bucket of 30, at one of our centers, 30 to 40 boarders at a time, okay? And so that's that ESI 3 plus patient, and when I talked about split flows, that's one of those split flows there you can identify that patient population, particularly if you have a provider in triage who can make that decision. Doesn't need a bed, just needs a test and then can wait and I'll get the results and get back to them. Okay, and then the last one that we recently implemented, particularly again at the higher volume centers, is we also implemented a ambulance provider in triage. And that individual, much like the provider in triage, works with a team of nurses and techs to get flow moving in the ambulance arrival area, which if you don't know Rhode Island, an ambulance equals taxi in Rhode Island. And so we have probably like the highest EMS utilization, at least that you've seen, right? Yeah, about half of our patients arrive by EMS. And then they get offended when you tell them, all right, now that you're here, you're going to have to ask you to get up and go to the waiting room. So we have an ambulance and triage, not for that reason necessarily, but for when we had boarding at a level that was highest, your most at-risk population is your highest acuity population. It's the ambulance arrivals, the 30-something admission rate. So put a provider and a team out there before they get to a bed and get medications, labs, tests underway. Do that, what I would call the equivalent of secondary triage, get them in and and you'll have more information before they even get to a bed. So we did this at our center. We identified these like 5 split flows, if you will. We said that we're going to prioritize a workflow for each one of these groups. Another example being transfer patients don't necessarily need to go, even though they arrive by ambulance, the same way that in ambulance arrival. They usually come with one singular question. Need ENT or need an evaluation by a consultant or needed to come over for an MRI. Those patients are sort of passive care and they shouldn't be put in the most efficient of care areas that you're trying to design your ED around. So we did this in our center. We actually, one of my medical directors presented this at last year's ED Innovations. This is what we did. So this is an intake team with that level of split flow, identifying those work groups, and an ambulance provider and triage type model, a provider in ambulance triage type model. And despite increases in boarding and arrivals, dramatic differences in door to provider, ambulance door to provider, which I would actually say is our most remarkable improvement here because those are the sickest patients again. And then obviously the reductions in left without being seen. Now, that's intake. That decision point right at the end of intake and throughput is what moves these patients into throughput, which we already reduced their length of stay because we implemented these changes up front. So throughput, as I mentioned, to active care time. Opportunities for process improvement you've probably done. I'm particularly a data-heavy person. We can talk about that later. Data-informed internal expertise informed by external expertise like the EDBA benchmarks, medians, is something you do interdepartmentally to improve your workflow. From a staffing standpoint, from a throughput standpoint, we're talking about boarding and staffing. Staffing is much less of an issue, at least for us, as it once was compared to boarding. Using RN extenders, LPNs, patient care technicians, paramedics for jobs that they can do, and freeing up RNs to be part of that intake nursing team was a big change for us and something that helped us improve our operations. Now, interdepartmental throughput, radiology and lab efficiency changes. We compare ourselves to the EDBA. We share it with the lab. We share it with radiology. We share it with the hospital administration. Same thing with our consultants. We have diagnostic and treatment guidelines. We have improved consultant efficiency as now one of the hospital, not KPIs, hospital goals. So we're tracking consultant times for our 4 major outliers and largest consulting groups, again, at the larger center of our group. So examples, the most efficient thing you can do for throughput is never to order a test in the first place that you didn't need. Okay, so ASAP Choosing Wisely campaign, we have tied utilization of that to our physician quality dashboard, which we provide to our providers. Following ASAP guidelines, having internal protocols for guidelines so that you're not CT the knee for orthopedics when that could be done inpatient. We do that all the time. And then other throughput examples are discipline-specific KPIs. We focus a lot on doc to dispo. We focus a lot on room to doc or door to provider. We are starting to focus also on process improvement that's not just physician discipline dependent. Examples are order to medication time or dispo to departure time and urine to order. For example, on that, we had a campaign, I know a lot of you, I think it's about 50% of people do collect a urine up front. It's the longest test turnaround time. So we had a campaign of you're in it to win it. That substantially reduced length of stay in that emergency department when we prioritized urine testing. That's simple. Again, you take one thing away from this, it is your urine is most likely, if you're not already doing it, most likely the thing that's slowing up your length of stay in that throughput phase. What limits your CTs? We're great for turnaround time if you look at the EDBA. Well, they're not great, but we're better than the median. But if you look up here, this is a heat map of our CT turnaround time. Again, I told you we're data heavy. The red is overnight, okay? So we might look good, but the reality is that the patients that come in at night are suffering through much longer CT read times. There's not more of them. It's just that the ones ordered at that time, because of staffing, and we found largely because of CT department staffing, we had a slow up in our CT reads. Okay, and then last piece, output, okay? Boarding in your emergency department. How many people cohort their boarders? Okay, so my question for those of you who didn't raise your hand is, why don't you cohort your boarders? You're trying to drive efficiency of your team, and your team, particularly the nursing portion of your team, has a number of new patients coming in and has to flex from inpatient care to ED care multiple times or throughout their whole shift. We started cohorting patients as part of that intake program that I talked about, and that had a significant difference in our outcome. It's almost like you're in denial. You're just hoping the boarding doesn't get bad, so you just keep having them intermixed with your regular patients. But we started acknowledging the fact that we're going to have about 20 to 30 boarders at our large academic site. And if we put them in an area when we don't have 20 to 30 boarders, well, heck, that's great. We have some free beds. What can we put in those free beds? Passive patients is what I would call them. Passive patients is the CDU patient, if you don't have a CDU, or you overflow CDU patients. Transfers coming in that need that consultant and you're waiting for a consultant, they shouldn't be in the ED proper where you're trying to turn through the undifferentiated acutely ill. And ED observation patients, someone's waiting an MRI. Okay, the classic patient, back pain, needs an MRI. They take up one of your most efficient bed care areas, where your most efficient, bless you, care team is, right? So we cohort those patients. So your boarders, your CDU, your transfers, your patients awaiting or having prolonged stay, try to cohort those patients in another part of your ED. Acknowledge that it exists. We know it exists. Acknowledge it's frankly not going to go away soon. And if it happens to you have an area of your ED to flex into. We expanded our CDU admission criteria for a similar reason. We added additional case management resources and then expedited discharge protocols for specialty care. And then the last thing that I would share with you is a little bit of work on facility offload. As I mentioned, we have a high admission rate. We have a high acuity patient population. We have a lack of primary care. So start identifying within your system where those little holes exist. I mentioned one of them, same-day clinics. I mentioned another where you have at least a 5 to 10% no-show rate in primary care clinics. We've started to fill those. The ED sort of metastasizing into those areas. So we will ask and now have next-day visit spots for our community primary care providers that participate within our health system. Our urgent care center has agreed to have us be able to place people into appointments for next day, 1 week, what have you. What that does is, frankly, that prevents an admission. So you go from a 26% admission rate down to a 25% admission rate. That's real bed space, right? That's a couple of beds, okay? And so that's another way of trying to work within a high boarding environment, is to just frankly not admit them in the first place. And so developing those relationships to offload out of the department so you don't need to admit people is just one more way. Thank you.